So yesterday I presented the colorectal specific data of the GOSAFE study, which is the Geriatric Oncology Functional Recovery study, which is looking at patients' recovery after surgery, where we usually think about post-surgical outcomes. We usually think about oncologic outcomes after surgery, especially for cancer, but less typically surgeons are thinking about quote unquote functional recovery, which is how people are able to get back to their typical activities of daily living, how well they're able to function in their environment after surgery, what their bowel function is like, urinary continence, etc. So the GOSAFE study is the first study of its kind, which is a prospective study looking at functional recovery after major cancer surgery and also looking at quality of life. This used to be kind of a secondary outcome, but we know that this really should be a primary outcome. And both the functional recovery and quality of life, especially in older adults, has been shown to be equally important to the patients as the survival from the cancer, which is typically the thing that the medical team is thinking about more and historically had been studying more. So we prospectively enrolled all cancer patients. It was supposed to be a real life study, so it was supposed to be consecutive patients. The only patients that were excluded were those that had a hospital stay less than 2 days, which was supposed to be kind of a metric for less intense surgery, and also emergency surgery. But all other patients were included. And interestingly, for the GOSAFE, patients who had cognitive impairments were also included. Typically, those patients have been excluded from other studies. So we were able to get a real-world look at these patients and how they recovered from surgery. So we found that we're looking at recovery at 1 month, which is mostly to look at post-op outcomes and complications, and then at 3 months and 6 months. So in our colorectal specific cohort, we were able to show that about a third of patients had full functional recovery. And we looked at that meaning that they had recovery of their cognition, of their activities of daily living, and also a timed walking test. So if they were able to show that they had adequate scores in all 3 of those domains, then we considered that to be full functional recovery. So about a third of those patients had full functional recovery, approximately a third had partial, and approximately a third had decline in all 3 domains. But interestingly, we showed that if patients had more than 1 complication, they actually had a double rate of not having a functional recovery, or having a functional decline is another way to look at it. So about greater than 60% of patients who had more than 1 complication had a functional decline. So the next steps is to finish looking at the 6-month data for the entire cohort, and then analyzing which of the tests are the most effective. Because right now we know that there are a lot of frailty screening tests, and different people use different tests, and so it's kind of hard to tell surgeons in particular who have a busy clinic which tests are most effective in determining which patients will not have complete functional recovery. And so being able to look at the tests that we use, because the initial conceivers of the study, which was a large group, including the surgical task force within SIOG, but also Isacco Mantroni, Riccardo Odisio, and Giampaolo Guglini were the main drivers of the study. And they really thought a lot about how to best measure this. So the next study would be to see which tests are most effective, and then validate that test for a variety of real-world cancer patients.